Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
And I want to now pivot to talking about how we do molecular testing and what are the things that a clinician needs to think about when ordering tests so that we can figure out whether patients with lung cancer have one of these driver mutations. When we think about testing, there's generally four categories that we're looking at, and they're shown here. We're looking at immunohistochemistry, we're looking at FISH, we're looking at PCR or next generation sequencing, and there's trade-offs with all of them. Immunohistochemistry, or abbreviated as IHC, selectively identifies antigens or proteins in cells of a tissue by using very specific antibodies. And so what happens is we're looking for proteins on the surface of a cell, and we design antibodies that would bind with certain proteins. And then we can visualize that binding through two different ways. One is called a chromogenic IHC, and the other one's called immunofluorescence. And so on the right here is an example of how we would use IHC to diagnose lung cancer. And common stains that are used to look at non-small cell lung cancer include the following: TTF1, napsin-A, P40, P63, CK7, and CK20. And this is what it would look like on the slide when a pathologist is reviewing these. Some practical applications are the following. So for resource-limited settings, IHC can actually be really useful to confirm the presence of an ALK gene rearrangement, and specifically if you use the D5F3 antibody. It will be used to determine PD-L1 tumor proportion score, and we'll talk a little bit more about that. And it will also be used as a target for antibody drug conjugate trials. And I've just listed several trials that are ongoing here. I'm not going to spend too much time on antibody drug conjugates, but I'll just briefly describe what it is. So an antibody drug conjugate is a monoclonal antibody, which we talked about earlier, but this monoclonal antibody is actually linked to very high doses of chemotherapy. So I often describe this to patients as smart chemo, because what you're doing is you're screening the cancer for the presence of proteins that this antibody can bind to, and then you're delivering chemo to just those regions. And below is an example of clinical trials ongoing with different antibodies and antibody drug conjugates. Now, we talked about PD-L1. So PD-L1 is a very interesting IHC stain. It, in lung cancer, is useful to allow the clinician to get insight as to how likely a patient is to respond to immune therapy. Now, each immune therapy, and there are many different types of immune therapies made by different companies, has a different IHC stain. The most common one is shown on the bottom right, the 22C3. This is the one that's the companion diagnostic for pembrolizumab, but other ones are also available. Some important things to think about when we talk about PD-L1. First things is PD-L1 is reported as a range. So when you get a report, the tumor proportion score will typically say something like 0%, 1%, 20%, 45%, 60%. It's a continuous variable from 0 to 100. But when you interpret clinical trials, you'll oftentimes see that PD-L1 is broken into what's called a categorical variable. So they'll say something like PD-L1 high or low. And this matters when we think about how patients are being grouped. I mentioned that different companies have different PD-L1 assays, and we talked a little bit about how continuous variables, so something that's ranging from 0 to 100, oftentimes gets grouped into high or low. And this is important because we know that patients who have very high PD-L1 scores are the ones that are largely driving response to immune therapy. This was shown very nicely in this paper here. When you look at the patients who have a PD-L1 score of 90 to 100%, these are the patients that overwhelmingly respond to immunotherapy. And so when we group this variable into high or low, we're sometimes missing the nuances of how many of these patients are actually greater than 90%, how many of these patients are actually greater than 50%.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.